Hello and welcome everyone. Greetings to all our participants joining from across India and around the world. On behalf of the Harvard T.H. Chan School of Public Health, India Research Center, it is my pleasure to welcome you to today's webinar, Shifting Boundaries, Climate Change and Vector-Borne Diseases. My name is Swati Bakshi and I serve as the Deputy Director at the Harvard Chan School of Public Health, India Research Center. The center was established in 2015 as the first global footprint of the Harvard Chan School. We work to advance health in India and globally through our three strategic goals of research, training and capacity building, and knowledge translation and communication. The center is led by Dr. K. Vishwanath, Lee Kamki Professor of Health Communication at the Harvard Chan School. Now, let me take a moment to briefly set the context for today's discussion. As we all know, climate change is no longer a distant threat. It's an unfolding reality that is reshaping our ecosystems, livelihoods, and most critically, human health. Its effects are felt across multiple dimensions, from extreme heat and erratic rainfall to rising sea levels and ecosystem disruptions that alter the delicate balance between humans, animals, and the environment. Among its many consequences, one of the most alarming is its impact on vector-borne diseases. Globally, vector-borne diseases account for more than 17% of all infectious diseases, causing over 700,000 deaths every year. And India, with its high population density and diverse climatic zones, remains particularly vulnerable to these climate-sensitive diseases. Recent years have seen rising trends in malaria, dengue, and chikungunya, with outbreaks occurring in new geographies that were previously unaffected. Changing temperature, rainfall, and humidity patterns are expanding the habitats of vectors such as Aedes aegypti and Anopheles mosquitoes, making transmission seasons longer and control efforts more complex. Beyond the statistics, this represents a major public health challenge that calls for stronger intersectoral collaboration, innovative surveillance tools, and adaptive health system responses. So, to strengthen the focus on this emerging issue and drive evidence-based action, the Harvard Chan School of Public Health India Research Center has launched a new webinar series titled Climate Change and Health, Science, Policy, and Public Health in Action. Through this series, we aim to convene global and national experts to explore how climate change is influencing disease patterns, discuss ongoing research and policy responses, and identify strategies to strengthen public health resilience in India. Today's session marks the inaugural event in this series, focusing on the linkages between climate change and vector-borne diseases, a topic of growing national and global concern. And now I have the pleasure of introducing our panel of experts for today's conversation. I'll begin with Dr. Daniel Neafsey, Associate Professor of Immunology and Infectious Diseases at the Harvard Chan School of Public Health. He also serves as the Associate Director of the Broad Institute's Genomics Center for Infectious Disease. Dr. Neafsey's laboratory studies the evolutionary genomics of malaria parasites and mosquito vectors. His current projects involve the application of comparative genomic and population genetic analysis to Plasmodium malaria parasites and Anopheles mosquitoes to study population structure, natural selection, and genomic factors underlying parasite and vector phenotypes that impact public health. Welcome, Dr. Neafsey. We are pleased to have you with us today. Next, we are joined by Dr. Mrinalini Darswal. Dr. Darswal is an Indian Administrative Services Officer of 2002 batch from the Odisha cadre with an extensive background in public health and governance. She has served across multiple states in India, including as collector and district magistrate in several districts of Odisha for nearly 8 years. She has also served as the Commissioner of Food Safety and Drugs Controller for Delhi, as well as Special Secretary of Health. Dr. Darswal holds a doctorate in public health from Harvard University. Currently, she serves as the Special Resident Commissioner for the state of Odisha in New Delhi. Welcome, Dr. Darswal. It's a privilege to have you with us. Next, we have Dr. Nilima Mishra, Director of the National Institute of Biologicals, Ministry of Health and Family Welfare. Dr. Mishra's pioneering work at ICMR, National Institute of Malaria Research, has led to several policy reforms in India's malaria control program, including the nationwide prohibition on oral artesunate monotherapy and major treatment protocol revisions in the Northeast. Her contributions to malaria research include the development of an innovative diagnostic method for Plasmodium detection, achieving an unprecedented detection limit of fewer than one parasite per microliter, for which she holds both Indian and international patents. Welcome, Dr. Mishra. We are delighted to have you with us today. And finally, we are glad to welcome Dr. Abhyant Tiwari. Dr. Tiwari is the lead for Health and Climate Resilience at NRDC India. His work focuses on climate and environmental risks to public health, advancing evidence-based adaptation and mitigation strategies. He played a key role in developing South Asia's first heat action plan in Ahmedabad and continues to support the expansion of heat wave adaptation plans across India. He also serves on expert groups of the National Disaster Management Authority and the National Center for Disease Control, guiding national climate health preparedness. Dr. Tiwari holds a Master of Public Health in Environmental Health Sciences from the Harvard Chan School of Public Health. Welcome, Dr. Tiwari. It's a pleasure to have you with us. So while these introductions are only a snapshot of our panelists' remarkable work, we are eager to hear their perspectives in what promises to be an engaging discussion. Today's session will be moderated by Dr. Gaurav Basu. Dr. Basu is a physician and assistant professor of medicine in the Division of Global Health Equity at Brigham and Women's Hospital and assistant professor of global health and social medicine at Harvard Medical School. At Harvard Chan School of Public Health, he is an assistant professor of environmental health and faculty at the Center for Climate Health and Global Environment. With his extensive work at the intersection of climate change, global health equity, and policy, Dr. Basu is perfectly positioned to moderate today's discussion. And now, before I hand over to Dr. Basu, here's what to expect over the next 65 to 70 minutes. So we'll begin with a 50-minute panel discussion, followed by 10 to 15 minutes of audience question and answers, and then conclude the session. I encourage all attendees to please post your questions in the Q&A box. Our backend team will collect them and share them with Dr. Basu for the discussion. And with that, I'll now hand over to Dr. Basu to lead today's discussion. Over to you, Dr. Basu.
Thank you, Dr. Bakshi. Thanks for organizing us and bringing us together and having such a wonderful panel. I'm very grateful to be a part of this conversation and eager to learn from each of our experts here as well. And thanks, Dr. Vishwanath, for all the work you do for the center, which has brought many of us with interest and concern of the impacts of climate change and health in India together. So let's get started because we all want to hear from these wonderful speakers. I'd like to start asking each of our panelists to give a brief 1 to 2 minute opening statement so that the audience can get a little bit of problem definition. We have this focus point of vector-borne illness in a changing climate in India. And so let me prompt each one of our panelists with an opening statement on, how concerned are you about the changing implications of vector-borne illness in India as climate change continues to impact communities there? What do you spend most of your time thinking about in terms of how it's impacting public health? So Dr. Neafsey, I'll start with you.
Sure. Thank you very much. And thank you very much for the invitation to participate in this panel. I'll just begin by saying that for many vector-borne diseases, we are still working on developing vaccines, and we are lacking highly efficacious vaccines for a number of vector-borne diseases. And so the best way we can prepare for the impacts of vector-borne diseases is by anticipating factors that will result in changes in their local incidence and preparing for those changes in their incidence. And so with that said, climate change is a very important topic for diverse vector-borne diseases because unlike diseases that are spread from person to person through aerosols or through droplets or through surface contact, vector-borne diseases are spread by mosquitoes. They're diseases that implicitly connect us to our ecosystem. And ecosystems are complex. So if we want to understand the impact of climate change on vector-borne diseases so that we can anticipate changes in incidence and prepare a public health response in time, we're going to have to take on this challenge of better understanding these ecosystems on a local level. And I'll stop there.
Thanks so much. Dr. Darswal.
Right. Thanks for the opportunity. I come from the perspective of a policymaker, having worked at the very grassroots levels. And I can say that not very long back in the past, the climate change discussions were kind of limited to the policy tables and elite drawing rooms. But as an officer who is the implementer of policies and who is the translator of all the wisdom, research, ideas that are being generated across, especially given my exposure at Harvard Chan, climate change is now ringing very close to home. So everybody in India and everybody across the globe is now feeling the pinch of what it is bringing to us. We have seen Himalayas being melted away through cloud bursts. There is an unprecedented loss of lives, which is unfathomable, but which cannot be controlled immediately because it has been a long drawn process. And there has been a focus on climate change, but unfortunately at the policy level, we have not been able to link climate change with vector-borne diseases. So we do have a vector-borne disease program in India, and we do have a climate change policy mitigation and adaptation, sustainable development policy, but they are not communicating to each other as of now. So I would like to bring the focus on this very fact and how now to convert all of these ideas into practical action on the ground. Thank you.
Thank you. I think what's wonderful about our panelists today is that we are really spanning that spectrum from basic science to policy implementation, and I think each of our colleagues here have really integrated, from the bench to policy, and so I'm eager to explore each domain of that spectrum today. Dr. Mishra.
Yeah, hi, good evening to all. Actually, if we say climate change, it is adding another challenge to the control and elimination of the infectious diseases. So as a researcher, what I would like to inform is that in the field, we have a lot of challenges when we talk about the control or the elimination of these infectious diseases. And with the introduction of this climate change as one of the emerging hurdle for our lives, the elimination of these diseases need new dimensions with the introduction of diagnostics, which are more sensitive and are field deployable. And maybe we can say that we need more innovative tools to tackle this situation. And since India is gearing to tackle this emerging issue of climate change, certainly there will be hurdles, but as we have now focused on the innovation and more on R&D in the current policy level, we are sure that as a scientist, as a researcher who has actively worked in the fields, we have the solutions to come up for tackling this challenge. Thank you.
Thank you, Dr. Mishra. Dr. Davari.
Thank you, Dr. Basu. So I'll just echo to all the panelists that while we were still struggling to address the issue of vector-borne diseases, which has been one of the longest challenge, not just for India, for the health system, not just for India, but for across the world. Uh, the climate change is making it even more, difficult to deal with. The transmission patterns are changing. Places where we have not seen, vector-borne diseases earlier, including in India, what um, the earlier panelist was talking about in the Himalayan belt, we are seeing the cases of vector-borne diseases there now. So yeah, the challenge is mounting, but it also requires a multi-sectoral approach, not just in silos. We have this National Center for Disease Control, under which we have National Program on Climate Change and Human Health, which also has a component on vector-borne diseases, which kind of, talks with the National Center for Vector-Borne Disease Control. But still, as previous speaker mentioned, panelist mentioned, there are still some gaps in doing the coordinated actions. Yeah.
Thanks so much. So let's, we again have a really nice mix here of, and many of them are both, but researchers and policymakers and implementers. And so let's start a little bit on the research front and tease out a few pieces here, and then we'll work towards systems change and policy implementation. But if Dr. Neafsey, maybe I'll start with you, but then I'll ask any of the panelists to chime in that can speak to this. Give us a little sense of what we understand, in kind of micro geographical adaptation about what do we know about how mosquitoes' behaviors are changing and redistributing in a country like India with the changing climate. Do we understand kind of the geographics of what and how mosquitoes are changing in the country?
Sure. Yes, Dr. Basu, I can respond to that. There's a lot of work that's been done on various vectors of disease, mosquito vectors of disease, and other arthropod vectors like ticks, how they respond to environmental factors like temperature or humidity or extreme rainfall events. What I can say is that there's a lot of local variation. So while each one of these effects is known to affect mosquito or tick biology and capacity to live in a certain place and transmit infectious diseases, it's the interaction of those effects and other local site-specific factors that combine to produce a very local effect, typically on infectious disease. For example, sometimes a moderate increase in rainfall can increase mosquito populations and result in an increase in arboviral transmission or malaria transmission 1 to 2 or 3 months later. However, if the rainfall all comes at once in a deluge, that can wash away mosquito eggs and actually reduce mosquito populations. So the effects are intricate and really warrant focal studies in regions that are concerned about the impact of a changing climate on vector-borne disease.
Yeah, with this vector-borne illness, you have to really embrace and the so many layers of mechanisms, right? With land use change, with flooding, drought, temperature. The modeling of all of this is so sophisticated because there's so many variables at play. Dr. Mishra, I might turn to you. So a lot of your work is, you did a study on asymptomatic low density and Plasmodium infections in Northeast India. And you were highlighting how kind of routine rapid diagnostic tests, microscopy could miss hidden vectors. So if you could speak a little bit to our diagnostics, how, if you can give us a sense of how well positioned are our diagnostics, the systems that are needed to properly diagnose, how much are we missing, how much is hidden, and kind of the systems gaps, the data gaps that are currently present in identifying, the incidence and severity of vector-borne illness in India.
Yeah. Yeah, so as you were talking about the study on asymptomatic low density plasmodium infections in the northeastern part of our country, what we have found is that since our national program employs rapid diagnostic test kits for the diagnosis of malaria as well as the microscopy. And at times, because of the you can say the some inadequate arrangements in the form of the trained microscopist, or due to the some false negatives in the rapid diagnostic test kits, there are chances that we may miss the detection of malaria in such cases. Certainly, with the decreasing malaria incidence in the country, there are still some challenges of, you can say, there are low density parasites which are unable to be detected by microscopy or RTTs. And there could be asymptomatics, which gives false negatives that they are not infected with malaria. We need technologies which can support the detection of these low density infections as well as the asymptomatics, so that the transmission reservoir present in these population can be tapped and can be treated on time. Like in our study in the northeastern state, we did mass survey strategy, mass screening and treatment. And with that, the impact of the study was that we could reduce the transmission in that area. And the national program was a collaborator. They took it forward, and the malaria from that particular area has almost reduced to near to, you can say, a few numbers present over there. So what we were looking forward is the introduction of the better and advanced technologies, particularly with the introduction of real-time PCR technologies during the COVID time. The infrastructure of these machines is available at the district hospital levels, which can be tapped by the national programs, and we can use them for detecting these LDIs, low density infections, to stop the transmission of the disease.
Okay, thank you so much for that. And I'll just remind the audience again, if in the Q&A button here on Zoom, if any questions are coming up, please do write those questions down, and we'll get to them at the end of the session today. So with that being said, if we could speak a little bit to, kind of data gaps and research needs in terms of kind of surveillance, monitoring, early warning systems. Give us a sense of how much work has been done on that, what is needed to be done. Anyone who might be able to speak to that. Dr. Dwani, yeah.
Maybe okay. So
Please
yeah,
go ahead.
data gap is a big challenge. So when we talk about doing climate modeling for vector-borne diseases, predictions, there is a big issue of spatial and temporal mismatch between the data, between the climate model, which are often of course resolution, which do not align with the fine scale surveillance meteorological data, which we don't usually have at village level or district level, or even at a smaller scale. So that is something which remains as a challenge. The data gap is also because of the underreporting and inconsistent case definitions that we often face. So health surveillance often misses the asymptomatic or mild infections, especially for example in dengue or chikungunya, which creates a bias training data for climate-driven models.
Okay, and maybe just we Dr. Bakshi spoke about it as well, and I think we've generally the audience probably has a good sense that things malaria, dengue, chikungunya. But could we just kind of layer out really briefly here, the disease, we're saying vector-borne illness, mosquito-borne illness, but if you all could just kind of map out here which diseases are of most concern. Are these kind of data gaps and diagnostic issues pretty consistent across those disease process, or are there specific considerations for the different diseases?
Yeah, I can just mention by laying out a few diseases. I think we're talking about malaria, which is actually caused by two different parasites, Plasmodium vivax and Plasmodium falciparum, that are the most important contributors to malarial disease in India. Malaria parasites are spread by Anopheles mosquitoes, one particular genus of mosquitoes. Other arboviral diseases such as dengue or chikungunya are spread by Aedes mosquitoes, Aedes aegypti or Aedes albopictus. I know these are of increasing concern in India. I think there are other diseases that in other parts of the world, there's also concern that climate change may impact their incidence, things such as Zika, yellow fever. So I think there's diverse types of mosquitoes, not to mention ticks, that I think we want to better understand how they will be impacted by climate change. And I would say that also another important factor in kind of understanding the landscape of risk to these different diseases and how that may change in the face of climate change is also understanding human immunity, because the level of antibodies in a human population to any of these diseases waxes and wanes with exposure, and the level of antibodies may influence, for example, the propensity of infections to stay asymptomatic or at low parasitemia and hard to detect. And so by just measuring clinical cases, this is partly a function of exposure to these mosquitoes or other arthropods carrying these diseases, and partly a function of how many pre-existing antibodies did someone have, and were they able to kind of keep the infection low or keep it from turning into a symptomatic case of a disease.
Thanks so much. Dr. Mishra and Dr. Darswal, maybe I'll bring this question to both of you, but anyone welcome to chime in. So this kind of One Health approach, is a framework that has had some increasing attention. Again, kind of embraces the bigness and the complexity and the many different mechanisms at play here. Some people feel daunted by that, right? Because it is embracing a very big mission. And so maybe, Dr. Mishra from research perspective and Dr. Darswal from kind of a policy perspective, can you define One Health approach? How is that in the consciousness of kind of response to vector-borne illness here? Is it a useful approach? How much is it integrating into your work, and how can it be of relevance to this?
So if I say that the One Health approach for vector-borne diseases, actually it involves a multi-sectoral strategy to manage the interconnected health of humans, animals, and the environment to prevent, control, and respond to diseases like vector-borne diseases like dengue, malaria, etc. So this approach includes surveillance of humans, animals, vectors such as mosquitoes, ticks, and implementing the integrated vector management strategies through which environmental and chemical control, treating both human and animal infections, using vaccines and social mobilization, fostering collaboration between public health, veterinary, and environmental sectors will help us in giving a scenario where we can actually tap the reservoir of infection. So this is we call as One Health, and there are a number of components when we talk about One Health approach for vector-borne diseases. This includes integrated surveillance, integrated vector management, what we call as IVM, then One Health informed animal health, environmental and ecological interventions, collaboration and policy integration, social mobilization and public awareness. And I'm happy to inform that the Government of India, under a Ministry of Health and Family Welfare, one institution has been instituted to tackle the One Health, take forward the One Health approach, and various ministries like the animal husbandry, the Ministry of Health and Family Welfare, the agricultural ministry, those all ministries will be working under one umbrella and will work together to eliminate most of the infectious diseases that can be eliminated if this type of approach is being used.
Great. Dr. Ashra?
Yes. Well, I must say that there is a difference between what ought to be and what is, because I will make 3 points here. First, to Dr. Neafsey's observation on understanding the antibody levels to kind of have an idea about the prevalence of disease and incidence. It's not that simplistic because dengue doesn't behave, and dengue is, I believe, the biggest threat right now with malaria incidence going down. And with rapid urbanization, where 60 to 70% urbanization in India is unplanned, with very scarce sanitation and water resources. Dengue has a special phenomena called as antibody-dependent enhancement. So there are four serotypes, and infection with one serotype actually enhances the severity of symptoms with others. So like Dr. Neafsey was saying, that it is a very, very complex phenomena, and we actually need technocrats instead of generalists to head all of these missions to actually understand all of these phenomena, which are very unique to different vector-borne diseases, and then transmit this education in simplistic terms to the populations. So because these are now household problems, the government cannot enter houses of people to control Aedes populations, which are like homebound. So we can spray outside, but we cannot like enter every household and spray the insides unless people allow us to. So that is one problem. And second, One Health approach, if it is confined to a singular ecosystem or a singular community, it would be very easy to implement. But we saw in the case of COVID-19, a zoonotic disease, and previously we saw in case of HIV/AIDS, that all of these diseases originate from very, very far away, and they are transmitted through geographical country boundaries. So we actually do not have control over the origin of the diseases in most of the cases. So how do we control wet markets in China so that those diseases do not travel to our country? It's kind of an impossibility, but yes, it is an ideal situation where we are able to control the zoonosis, we are able to control the diseases in the animals like rats, so that there is no spread of ticks and other things. But it is easier said than done from a policy perspective, and especially from the perspective of a regulator working in a country like India, where there are so many geographic zones, ecosystems, different diseases, different region, different population responses, different genetics, and different antibody levels. So we have to go at a very large scale to actually implement One Health, and their coordination with agencies like WHO, which is now kind of many countries, including US of A, they don't want to work with the WHO. With these kind of coordination problems, One Health approach is very, very difficult to implement. But at local levels, and again in India, health is a state subject. So every state have their own policy for health. So bringing everybody on a singular table to ideate on similar lines to implement a singular policy across India we need a lot of coordination, but that awareness is kind of building because we are now interconnected at a level which is again unprecedented. We are learning from each other. We are understanding that diseases know no boundaries. So unless we coordinate, unless we cooperate with each other, we will suffer. So that understanding is there. That being said, One Health approach is an ideal approach, but it is going to be a long drawn process to actually implement it on the ground.
it's a moving target that you're, vector-borne illness does not know boundaries, and constantly the dynamics are changing. And so it's a very active, and it's heartening to hear the increased level of coordination among state actors and the learning that's
But
coordination
one
being.
positive example I can give is in case
Please.
of flu vaccines, where we go to the origin in China, study the emerging influenza virus, make the vaccine in advance, and then transmit it across the globe. So that is like kind of one example of One Health without calling it as One Health.
Yeah.
So
And
that
it can be
is
a model to be addressed, to bring to other. Um, let's talk a little bit about kind of early warning systems. So, Dr. Tavari, I'll bring this to you. You had a study on dengue. Dr. Darswar also was kind of highlighting the importance of dengue. So I think you had a study this year on dengue dynamics, predictions, and future increase in changing monsoon climate in India. And with that study was showing, how rainfall and temperature, humidity all drives outbreaks in kind of complex, nonlinear, region-specific ways. So could you tell us a little bit about that study and tell us a little bit of what its implications are for kind of early warning systems in India that could help with forecasting that are reliable and also actionable?
Yeah, sure. I think you're referring to the study that was done with IITM Pune. Yeah, and that was for the city of Pune. Uh, the first challenge was to get the data itself. We used the random forest model, incorporated several, machine learning methods to come up with an early warning tool which can predict the probability of dengue outbreaks in a given area if you feed in the information into the model. Now we have this model ready. The problem lies with testing it, and the problem lies with scaling it. So for scaling you need agencies like local health department and local weather department to take it further, because the research institutions do not have that prerogative that they will be doing the early warnings early warning work. So what we can do is we can come up with models which need to be tested, and then need to be scaled with the support of local authorities. So we have been in dialogue with the local meteorology department and the health department on how to further strengthen the model with more data, and also how to build an early warning system, entire system through which an early warning could reach to all the target, like how we have it for other let's say disasters. We have like we now have CAP, common alerting protocol, but something like that cannot be done for diseases like vector-borne disease. So we need to think effectively, like on how these early warnings, which are built on the such models, can be further percolated to the communities.
Okay, thank you. And maybe I'll open this to any of the panelists. Of course, these days, any great challenge, machine learning and AI is on the mind. We'll highlight, of course, we need to be conscious of AI's climate impacts in and of itself, but obviously, this kind of machine learning offers this potential for a lot of forecasting and early warning system work. So we'll ask how much is machine learning and AI currently being thought about in terms of solutions, and in what ways?
I can take that as again a policymaker. I work in the state of Orissa, and it's a coastal, hot and humid state with a lot of vector-borne incidents. We have started talking about AI and machine learning in health systems, but we have it's just like in Kuwait initial talk. We have started with allowing IAS officers and others to buy AI platforms and start working on those. But specifically, AI and machine learning have not been brought into government level modeling and predictions, but we are going to do it very soon. Like I said, again, we need technocrats. We either bring in all the expertise in one person, like I am a physician, I'm a master's in AI, I'm a master's in economics, and I've been a policymaker for 25 years. So I can think these thoughts on a daily basis. But an officer coming from, say, a psychology background will have to pick up a lot of stuff along the way to think on those lines. So we really have to bring in, so we can create teams which have these attributes, and then we focus on a problem and then bring in solutions which has AI and machine learning incorporated. Because I believe personally that future is technology. Climate cannot be tackled without technology because it is all about forecasting. Previously, I used to read about complex systems and that butterfly flutter effects and all that. We cannot predict weather patterns very, very acutely but and accurately, but it is becoming a reality now that we can predict weather patterns much more accurately than before. And I think it can come to a great use to us as modelers, as policy implementers, as forecasters, and as investors, to bring in more efficiencies into bringing in policies and bringing in solutions for control of vector-borne diseases using AI and machine learning for predictive modeling and policy based on that predictive modeling.
Thank you. And Dr. Neafsey, I might pull you into this in terms of the genomics and your work in the research, or any comments you had on machine learning.
Yeah, certainly. If I can just add to Dr. Daswell's points, I think she's made some excellent points. I would just like to emphasize the importance of data. I think there is definitely potential to explore AI tools like large language models to complement or extend the predictions of existing mechanistic models that link climate to incidence of vector-borne disease or weather events. But all of these AI approaches don't run in a vacuum. They require data. These huge data centers that are built to parse text to train better models of ChatGPT harvest enormous amounts of text produced by humans. And so if we want to see AI, create inroads for this particular problem of humanity, we need to be collecting data to inform these models. And this is both, meteorological data, climatological data, entomological data, and serological data and epidemiological data. I think genomic data has a role to play, for example, in understanding whether climate is having direct versus indirect effects on the local incidence of vector-borne diseases. And by direct effects, I mean perhaps changes in climate may be amplifying local mosquito populations and causing enhanced transmission of local viruses or parasites. By an indirect effect, I mean that perhaps climate change results in altered patterns of human migration, and perhaps local mosquito populations are staying the same, but more people are arriving infected with a particular disease from other places because of climate-induced changes. They're both important for public health, and to be able to model those and understand them and then respond effectively requires the ability to distinguish them. And this is a case where we can use genomic data and kind of the genetic fingerprint of viruses or parasites and mosquitoes to understand if they are local or if they've been imported from somewhere else.
That's really fast. It's to really tease out the layers of interpreting what you're seeing. Again, so many different variables at play. So that gives me a lot of insight on kind of why we need those fingerprints to understand what it's telling us. Dr. Darswa.
Yes, regarding genomic surveillance, one good thing that came out of COVID-19 pandemic was establishment of INSACOG, which is Genomic Surveillance Institution in India. And I think many other countries also established genomic surveillance units because of the necessity. And now that can be used for other diseases. I wanted to ask Dr. Tiwari, he has done this heat map prediction modeling for Ahmedabad, and I want to understand whether he's been able to use all of these modern approaches to integrate into his model, and how can we use his approaches to other areas in India?
Sure, Doctor. That's all. Thanks for that useful question. So in Ahmedabad, we did two modeling, one for the early warning system, which was a time series analysis using the historical weather and mortality data. Luckily, city of Ahmedabad has a very good, birth and death registration records, which is digitally available. So that helped us in, coming up with the local thresholds for the local early warning system, because if we go by the heat wave definitions in our country, there are umbrella definitions. So for all the plains, there are certain cutoffs. For all the hilly regions, there are certain cutoffs, and for coastal regions, there are certain cutoffs. But that does not apply the same. How the heat has been experienced in, let's say, in the city of Churu in the state of Rajasthan is totally different than how it is experienced in Lucknow. They both are plains, but they both are still different, experience different climatology. So and that's where the local thresholds are very important in early warning systems, where this data helped us in deriving the local thresholds. Other thing is doing the uh, high resolution ward level heat risk mapping, not just by using the hazard data, let's say temperature and other variables of weather data, but also using the socioeconomic and demographic data into the model, so that we can come up with a composite risk score that which wards are at higher risk compared to the other ones, and then the resources can be deployed based on the evidence. So that helped the city a lot, but apart from that, I would say the bigger reason for the success of that heat action plan, which has got scaled, we are working with many cities and states, and there are many organizations now who are working with governments, local governments, in supporting, providing them technical support in heat action plans. But early warning, risk assessment, uh, interagency coordination, which is the core, like there has to be a coordination mechanism to disseminate the warnings, to look after all the actions are being taken and monitored regularly, both the short term preparedness and long term mitigation measures as well. So that remains as a core, and definitely public awareness and community outreach, as much as it could be done effectively, is what translated this entire policy into success.
Thanks so much for that. All right, we have a few more questions, and then we'll turn to Q&A pretty soon. Dr. Mishra, let me turn this question to you, and this is a big topic, so we'll ask everyone to chime in a little. Let's talk about vaccines and where we are with vaccines, where we're going with that. Can you give us a little sense of where we are with vaccine development, and how you see in the coming years its role in addressing vector-borne illness in India?
Yeah. So basically, if we talk about these vector-borne diseases, vaccines are coming and they are providing efficacy ranging from, say, 60 to 90%. But currently, a number of vaccine targets are in pipeline, and we are looking forward to various trials where we expect that we will be getting better and more efficacious vaccines. If we talk about dengue vaccines, yes, there are trials which are in phase 3, and we are getting good results. ICMR, Indian Council of Medical Research, which is a premier organization under Ministry of Health and Family Welfare doing biomedical research. A lot of trial sites are being functional, and vaccine trials are ongoing. And certainly there is need that we come up with these vaccines so that we can prevent these diseases, since in the country these diseases are very near to elimination. And with the introduction of these efficacious vaccines, we will be able to meet the target of elimination.
Great. Well, that's it's good to hear that. And maybe I'll ask again. It's so wonderful the kind of spectrum of intervention that each of these panelists really um, have worked with. Such a diverse experience. Dr. Mishra, maybe staying with you here. From vaccines now, I'll ask you. You've done some work on community-based interventions. Can you speak a little bit to that? What is some of your community-based intervention research shown? What are the biggest challenges and behavioral changes? What are the gaps in awareness and kind of community-based interventions to adapt and respond to vector-borne illness? What are some of your insights from that research?
Yeah, so basically, if we talk about the gaps in the behavioral aspect, if we want to prevent these diseases, certainly we know that there is a little less, you can say, perception. There can be some other priorities of the population. Then there is a you can say that the sustained community engagement, and at times in our scenario we have some cultural inhibitions also, which gives you can say that those practices actually like we can say that earlier it was some water storage in the houses that was promoting dengue breeding inside the urban slums or populations. But with the introduction of more of IEC, BCC interventions, these type of practices are now being stopped, and we are having better practices for storage of water, the defecation, and those things. And other challenges are like there are certainly there are inadequate infrastructure to support our these initiatives. So the country has taken up those aspects, and we are working day and night to meet those challenges and come up with better solutions.
Thank you so much. Okay, well, one more, Dr. Darswal and Dr. Davari, maybe I'll send this question to you both. Vector-borne, like this is true, I think, of all climate-related impacts on public health, vector-borne illness not being any different. The vulnerable communities are most vulnerable. There are special considerations of understanding which communities, which disempowered communities are being harmed in particular ways. Maybe could you both speak to, and anyone really, this is permeates all of your work. What considerations do we need to have in terms of equity and vulnerable populations, and how do we operationalize some of that work? Dr. Darswal, maybe we'll start with you.
Yes, because again, as a government officer, we have a duty to look at the vulnerable populations first. Like I said, these vector-borne diseases are basically spread in areas where there's a lack of sanitation and proper water storage facilities, like Dr. Mishra was mentioning. And Indian urbanization, we have very rapid urbanization happening in India, a lot of migration from rural to urban. And we have also rural area developing on urban lines, which is very haphazard and not planned. And all of these areas, especially urban slums, are inhabited by vulnerable populations, socioeconomically weak, like Dr. Tiwari was saying, that he has a different mapping for socioeconomic status because those populations are affected very differently and more severely than the rest of the populations who can actually afford diagnostics and treatments, even and vaccines. Uh, so many vaccines in India, like dengue vaccine and other vaccine, like Dr. Mishra was saying, we are developing, but they are not available through the government programs. So those who can afford, they can buy from the open market, but these vaccines are costly. So again, the burden of disease largely falls on the vulnerable populations. So in our climate mitigation plan, we do have a mission for urban sanitation and urban water supply, but it is not directly linked to vector-borne diseases. But indirectly, if that is implemented, if enough money is pumped into that mission and that is implemented and our urbanization becomes more planned, with better sanitation, sewerage, and water supply facilities, then these people, these vulnerable populations, will not be constrained to store water, which in many because they are very busy earning a livelihood, so it is very difficult for them, and even very difficult for me also to check all my washrooms and see whether my water storage containers are properly covered and whether there is any breeding, because it takes time and it takes intention and it also takes agency, which many of these vulnerable populations lack. So, of course, creating awareness, like you were saying previously, educating the population to take care of their own health, generating health seeking behaviors at a larger scale, and taking care of hygiene and sanitation not only by the households but also by the municipalities and the wards is extremely important. And yes, the major burden of vector-borne diseases is indeed borne by vulnerable populations in India.
Thanks so much. Any others like to speak to this? It's a very detailed response.
Just to add to what Dr. Darswal was saying, so yes, like any other climate sensitive, diseases and conditions, vector-borne diseases are also affecting, disproportionately to the people, particularly the poor ones, the informal urban slum residents and migrants living in the ghettos. They are at the high risk. What apart from our health systems, intervention we need to do is, as Dr. Darshwal rightly mentioned, is engagement with the community. So, often our awareness, messages or awareness materials that reaches, even if it reaches to the vulnerable communities, those slum households, uh, where the, hygiene and sanitation conditions are poor and are the breeding beds of the, vector-borne diseases, even if it is reaching there, we need to make sure that the information is reaching there in their vernacular, language. It is, if whether they are understanding it or not. So too much of science in our communication often, results into no understanding from the communities. So that has to be taken care. For example, in heat, I mean, in for malaria also, we have done a lot of, you know um, uh, progress in awareness campaigns using different platforms and different methods, including videos and awareness, campaigns and billboards and leaflets and pamphlets. But we need to make sure that they are done in multiple languages and so that people can understand that.
Thanks so much. Okay, let's turn to some Q&A questions now. And I'll ask each of our panelists, we're going to close we'll be asking you kind of a closing statement, maybe highlighting two issues that you think, listen, these are top of mind things that I want to work on, that we need to work on through civil society and government to make solutions. So, what are the two solutions you're thinking most about and would like to kind of highlight? But some questions from the audience here. So one, so could aggressive vector-borne control measures like pesticides or, trying to bring down mosquito activity, could that solve one ecological problem while creating the other? Again, there's so many complex intersections here. So how much do we understand about how interventions may create unintended consequences, and how much does that factor into your thinking?
I can respond to this perhaps by noting, first of all, that the Aedes mosquitoes that are the most important vectors of viruses are not native to India. They're an African mosquito that's been spread around the world by people as an invasive species. And so any efforts directed towards Aedes mosquitoes or Culex quinquefasciatus mosquitoes, which can transmit diseases such as filariasis, they're not native to India or to many of the other places where they transmit disease, and targeting them therefore I think has the potential to enhance the local ecosystem if those approaches can be quite targeted. India, of course, has native Anopheles species of mosquitoes which are capable of transmitting malaria. But many of these anophelines are quite specialized. The most important vectors for malaria are quite specialized on feeding on humans. And there's a diverse array of Anopheles mosquitoes that live in the world, and only about 10% of them are actually important vectors of malaria. Typically, if you remove one species of mosquito or target a species of mosquito, there are not large ecosystem-wide effects because there are typically dozens of mosquito species in any particular location. So I think the public health benefits typically outweigh the environmental consequences of targeting mosquitoes for control. Although, of course, complete less interest of insecticides, obviously, it does have the ability to cause harm to the environment.
Any other comments on that? Okay, we have there's a couple questions that I might bundle a little bit together, and I think we've kind of touched
If I
upon.
may add
Oh
to
yes,
Dr.
please, go ahead.
Because I could read some questions about Wolbachia and other such interventions, and I've been like interviewing ICMR scientists extensively, vector-borne disease scientists extensively on this issue as a part of my research at Harvard Chan. So the problem with Wolbachia is that we are releasing hordes of new mosquitoes, and it is the value of the mosquitoes to bite. So although Wolbachia is not going to transmit the disease, but it's going to bite. So I was made to understand that the quantum of Wolbachia we need to release to the environment to eliminate the disease causing Aedes and other Anopheles and others is quite large. And their bites are pretty irritating. So populations where we have tested these, like some parts of Tamil Nadu, have not been very accepting of this intervention. So we really have to look at these factors as well, whether the local communities, whether it is even if it is a beneficial intervention, whether they would be agreeable to adopt that. So that is also very important from a policymaker's point of view. An intervention may work, but it is not accepted by the community. That puts a full stop to a very good intervention.
Thanks so much for that. So there's a few questions here that maybe I'll bundle together. I think we've touched upon this a bit, but and perhaps you've already spoken to some extent, but maybe we can speak a little bit more to it. That we've the impacts are local, community interventions are local. Dr. Davari, I think you've done work on kind of local action plans and the impacts of that. So there's some comments here saying, how do we conceptually, how do we create local action plans on vector-borne illness? Dr. Darswal, you spoke a little bit about coordination among states and all that. So maybe I'll turn this to Dr. Davari and Dr. Darswal to start us. Is give us a little sense of, how do we do the local to the state to the national interventions? Where should the emphasis be put in action plans? How is that? Give us a little more insight on how those are coordinated. For a city that there's value in doing these local interventions and action plans, but so many of the factors and impacts are being playing out, across borders, across state borders. And so how is a local municipality actually able to have, the ability to take action? How do you navigate some of those dynamics?
Well, I can start with the fact that India has one of the most beautiful and one of the most functional local level public health systems among all the countries in the world, which is currently called as the Ayushman Bharat or Prime Minister's Jan Arogya Yojana. And previously it was the public, the PHC level and CHC level, the system. So we have health and wellness centers practically catering to 1,000, 2,000 populations, under which we have village level committees, which are called as nutrition and sanitation committees, which are very well aware. And you might have heard about our local level health functionaries who are locally trained women called as ANMs and ASHA workers. And these have a very extensive understanding of the local diseases, their transmission patterns, their prevention patterns, their testing patterns, and also the local treatments with the paracetamol in case of a fever before a person is sent to a doctor. And I made a study comparing the two systems in US of A and in India during COVID-19, understanding what worked in India so that we were able to put so many vaccines in so many arms, like in very, very short span of time without any health hesitancy or vaccine hesitancy, which is a major issue in countries, in developed countries, because people are in connect with these local level health workers on a daily basis. There is a family level connection and there's a lot of trust which has been built over the years. So yes, there is a lot of understanding at the local level. So whenever a program is implemented in India, whether it is a malaria control program or vector-borne disease control program, our army is actually, our foot soldiers are actually all of these people who are working at the very grassroots. And I have been collector and district magistrate for 5 districts in Orissa and some districts in Manipur as well. So I have seen all of these foot soldiers working with a lot of sincerity at the local level, and these are our major data generators. So Indian Disease Surveillance Program, which is again a very extensive real-time disease surveillance program, which is now using AI to do disease mapping, which is again we are doing at an initial level right now, but it is going to scale up very, very fast. We get data at the national level from a single tribal village level if there is an outbreak in real time on the same day, and our rapid response teams are mobilized on the same day and they go to the spot, they do active surveillance, they take samples, they do communication, they do education, and they take all the preventive steps. If we were not doing it, we would have so many epidemics that we would be suffering at a very, very great scale. So these unsung heroes, these silent foot soldiers are working day in and day out so that India doesn't see major outbreaks very frequently.
I mean, that's a pretty extraordinary and inspiring thing to describe, and it certainly is at the heart of how we address these impacts on local communities. Dr. Davari, do you want to add anything? Or
I mean, Dr. Daswal actually covered it very well, but while there is no doubt that our health workers, the frontline workers, are our soldiers, and we have seen that in COVID, everyone saw that in COVID, and and we know from the great public health system that we have, which is primarily handled by these health workers, health workforce, is what is keeping our communities protected. Coming back to your question on how these local action plans are being developed and how do they coordinate from local to regional and regional to national. Uh, so so while our health workers are, they are the soldiers, a lot of burden is given on their shoulder. So there need to be a coordinated multi-sectoral approach, not just health systems approach. So what we see, outbreaks, we go and control that, but we are not contributing, it's not health department's role to go and do things which fall under other departments and which contribute to, such kind of outbreaks or other diseases or epidemics. So it has to be a multi-sectoral prevention and response approach both, and not just one sector alone. Then there has to be a regulatory mechanism. Thankfully for health system, we have malaria disease control program, vector-borne disease control program, uh, which is largely driven by from center to local level, by health system only, health department only. So there is a good system already there in place for vector-borne diseases at least, uh, and finance. So what we require for local action is there should be finance from central to regional to local, and there should be a regulatory mechanism, and it has to be multi-sectoral. So I think the multi-sectoral thing is only what is missing in this one, and maybe Dr. Daswal can correct me on that. Otherwise, we have a good regulatory mechanism at least to respond to malaria or any vector-borne disease outbreaks from the health department, and a good finance mechanism also in the place.
Great. Okay, we just have a few minutes left. We actually just have 4 minutes. So let's close. I'll ask if everyone could keep it a bit brief, but let's just, if you were to advocate for one or two interventions, solution-oriented interventions, what would those be, and what identify what the most important next steps are and what you'd like to do about it. And again, sorry a little bit brief so that everyone gets some time in. Dr. Mishra, we'll start with you.
Yeah, so currently there is need that we should do more surveillance, and surveillance in, say, in remote areas where we find that the transmission has become perennial. We need to stop that transmission, and the what we talked right now, that the One Health approach will certainly help us in tackling or in blocking the transmission. That is the current need. Another is the use of more sensitive technologies, high throughput technologies, and the technologies which can help us in detecting the asymptomatics, the other kind of hidden reservoirs. Those are the approaches which are currently needed so that we can tackle these infectious diseases, the vector-borne diseases, and can protect our population from this menace.
Thank you. Dr. Neafsey.
Sure, I will just echo some of Dr. Mishra's points. The impact of climate change on vector-borne disease is going to be complex and local. So I think we need surveillance, we need data that is collected locally, and ideally, to make best use of it, that is collected in a consistent way and that represents diverse aspects of the determinants of vector-borne disease incidence that include the environment, the vectors themselves, and people, immunity, and sociological factors. So the consistent collection of data on a local level is going.
Thank you. Dr. Davari.
Yeah, I'll reiterate some of my points that I made in my earlier answer, that we need to not just be responsive or responding or reacting to the situations, but also need to plan better. So we know that by mid of this century, majority of population in India will be living in the urban settlements, and the future infrastructure for that, future urban population, majority of that is yet to be built. So if we plan better, if we do better urban planning and infrastructure planning, which can help, or which incorporates vector consideration into the drainage, housing design, water supply, waste management. So that will at least prevent a lot of future load from our health system in the times to come.
Dr. Darswal, you have the last word.
So yes, I heard everybody, and I'm actually going to do. I'm not going to say that these things need to be done. I'm actually going to do two things. Number one is bring together departments of health, environment, and urban development on a singular platform to tackle all of these challenges which we have discussed today. And Dr. Nipsey, we have a lot of granular data in India. In fact, individual level health data, which is available across the country. Only thing is, this data is not being utilized for because of the lack of resources. So I'm going to use AI, machine learning, and other big data approaches to get this data work for us in predictive analytics, and draw my policy insights from these data. So these are the two things I am going to do as an officer. And since I have the last word, it falls on me to thank everybody, thank India Resource Center to giving me this opportunity to participate in this excellent discussion and learn so much. And I would like to keep in touch with all of you so that your insights help me again to serve people of India better by translating your research and your ideas and your insights and your wisdom into implementable policy. Thank you.
Thank you so much. So it's nice to end on not we should, but we will, and with this this extraordinary expertise and collaboration, and not just technical expertise, but really thinking about how communities come together to make change. I found this conversation quite inspiring and activating. So thank you for all of your work. Thank you to the audience. We had a really nice attendance and interest. And let's keep thinking and working together to address this important issue in India. Thanks again to the India Research Center, and we'll see you next time.
Thank you.
Thank you all. Thank you so much. Really appreciate it.
Thank you. Thank you.
Nice to meet you all. Let's
Yeah.
stay in touch.
Yeah. Thank you. Bye.